Hi, everybody. My name is Amanda Tenhoff, and I am a fourth-year PhD candidate in biomedical engineering at the University of Minnesota in the Visible Heart Labs. My presentation today is titled Aberrant Coronary Artery, a rare congenital anomaly examined through pre- and post-procedural 3D anatomical modeling. To start off with some background, in healthy human anatomy, the coronary arteries branch off of the right and left coronary sinuses, or right and left cusp of the aortic valve. The right coronary artery originates from the right sinus, and the left coronary artery, or left main, as shown, originates from the left sinus. In the diseased anatomy, or aberrant coronary artery anatomy in general, this can refer to any abnormal origin and/or course of either of the coronary arteries. For our specific case, this patient was diagnosed with aberrant right coronary artery and exhibited anomalies in both origin and course of the RCA. The RCA origin was off of the left sinus and also ran an intramural course, such that it ran within the arterial wall of the aorta itself. Additionally, the RCA had an interarterial course, meaning that the RCA ran between the pulmonary artery and the aorta. This presented a life-threatening situation for the patient, so this needed to be treated. The procedure the patient underwent is called coronary unroofing. This procedure has three main steps. First, the area where the right and left leaflets of the aortic valve meet, called the right-left commissure, was detached from the aortic wall. This allowed for visualization of the intramural section, which was then opened up to the interior of the aorta by cutting open that shared wall between the RCA and the aorta. In effect, this moved the right coronary ostium, or takeoff point from the aorta, more toward the patient's right. Lastly, the valve commissure was then reattached to the aortic wall. More of the anatomical details can be seen here. It can be hard to tell what is going on from the CT images themselves, so the main takeaway here is that the right coronary ostium, the RCO, has moved farther away from the LCO in the post-procedural anatomy. This is due to the unroofing procedure, which opened the intramural segment's shared wall between the aorta and the RCA, which is shown in the yellow circle. This can be more easily visualized in the model images shown. Here, we can see in the pre-procedural anatomy on the left that the RCA takeoff point is much closer to the LCA and in the left coronary cusp, but has moved more toward the right coronary cusp and farther away from the LCA in the post-procedural anatomy. The result, then, is that the RCO has effectively moved to the right sinus, which is more representative of a healthy anatomical morphology. This translation of the right coronary ostium was also appreciated through some simplified quantitative evaluation of the 3D models. Additionally, the models were incorporated into virtual reality for further visualization of the RCO movement toward the right sinus. One of the main takeaways from this case is the value of having multiple imaging modalities, in addition to patient-specific 3D modeling, for increased case understanding, particularly for such complex anatomies. In future work, we are looking to incorporate patient hemodynamics into flow studies for a better understanding of pre- and post-procedural hemodynamic change, in addition to anatomical change. We will also be incorporating these models and relevant information into SketchFab and the Atlas of Human Cardiac Anatomy for increased access to a variety of heart models to aid in understanding congenital heart disease and other cardiac diseases through the visualization of real patient anatomy. With that, I thank you for your time, and I welcome any questions.